Thank you. I'm Marian Mulkey with the California Healthcare Foundation, and I, too, am really glad to be here with you today. I speak up here a lot, and it's really a delight to look out at a room where I don't know very many faces at all. And so I appreciate you all taking the time out of your day to learn more about this topic that those of us who know about, care a lot about, and others sometimes may find a little eye-glazing. So I think we're all going to do our best to keep you with us as we go today. I'm going to start here. My task is to describe to you two aspects of the coverage parts of the federal law, both the effects on public programs like Medi-Cal and the effects on the private market through the exchange. But before I did that, I'm going to give you just a little bit of context for why coverage is so central to the law. Then go through some of those provisions both on coverage and on the related changes in benefits and access. And finally, just give you a little bit of a forward-looking glance at where California in particular stands with its implementation efforts. So a few charts. The cost of health coverage, both privately paid for and publicly sponsored, is a huge motivating force for the conversation that we've been having for some time in policy circles on health reform. What you see on this slide is that health insurance premiums have been going up for years at a rate that far exceeds the rest of the economy, overall inflation. This is true in good times and bad. It's worse some years than others, but there's a big gap between those two lines. And that more rapid increase in premiums is felt by all the people who pay premiums, employers, individual purchasers, and public programs as well. And this chart, looking at Medi-Cal spending, shows, too, that expenditures have been going up quite steadily for the last decade, as has enrollment, partly because need has increased, especially in the recent economic downturn. But this is one reason why in our state budget conversation, there's no escaping a conversation about public coverage programs. Even though Medi-Cal spending has increased at this kind of rate, however, the expenditures per beneficiary have actually been much more modestly increasing. So public program spending has actually gone up at about the same rate as inflation, in stark contrast to private insurance premiums. This is for good reasons and bad reasons. The unfortunate reality is that one way that Medi-Cal expenditures per beneficiary per member are kept modest is by reducing the amount that providers are paid. More on that as we go forward. So to give you a little orientation to our current landscape of public coverage programs, Medi-Cal, as Karen mentioned, California's version of the state Medicaid program, is a central and important source of coverage for many people in California, but it is limited to what are called, in the jargon, categorically eligible populations. You have to fit a certain set of criteria. You have to be a child. You have to be a pregnant woman. You have to have certain characteristics in addition to low income today to qualify for those programs. The income limits vary by population. So depending on what category you're in, if you're pregnant, if you're a kid of this other age, you may or may not qualify with the same household income. So we have evolved a sort of convoluted definition for who qualifies for this coverage support that is really quite complicated today and leaves many people out, as you'll see in a moment. Importantly, childless adults, no matter how poor they are not currently eligible for the Medi-Cal program. And there are complicated rules about assets and income that are sort of the gatekeeper to let you into this program. Healthy Families is a more recent program that covers children only to a somewhat higher income level, and that does not have those same kind of categoric requirements. Both of these programs, as mentioned, apply only to legally present people. Both Medi-Cal and Healthy Families are jointly funded between the federal government and the state government. Medi-Cal at approximately 50-50, half paid for by the federal government, half paid for by the state. Healthy families at about 2/3, 1/3, a larger share for the federal government. So again, they're linked importantly in the policy context, and there are fiscal implications, neither of which are fully in the control of either Sacramento or Washington. So this just shows you graphically some of those gaps in eligibility for public programs today. The Medi-Cal mandatory, those red bars, are the categories of people that the federal government says, if you have a Medicaid program, you have to cover people at these levels. So infants up to 133% of the federal poverty level, and young children at a higher level, kids up to 19, just at 100% of poverty, and so on. The optional, the yellow bars, are things California has elected to do that goes above and beyond the federal requirement. And the blue bars are that new Healthy Family Program called CHIP nationally that goes even beyond that for children, but not for others. The notable gaps here, and I should say here that 100% of federal poverty is about $12,000 for a single person, $18,000, $19,000 for two people. So this is not a lot of money, annual income. The notable gaps here are for childless adults who are left out entirely of this picture. And again, no matter how poor they are. Summing up across these different sources of coverage, this chart shows you where people in California today, people under 65, get their health insurance coverage, or in the case of the uninsured, don't, and how those have changed over the last 9 years. So green bars are 2000, blue bars are most recent data, 2009. And there are a couple of takeaways from this chart. First of all, employer-based coverage remains the primary source of coverage for most Californians, covering more than half of the people who live in this state. But Medicaid, our Medi-Cal program, is a really important source. Almost 20% of people, about 7 million Californians, and individually purchased coverage is another 2 million people, or about 7% of the population. So there are different sources, but employer coverage is a bedrock source, and it has been for a long time. The goal of the Affordable Care Act is to build on all those sources, fill in the gaps that aren't there, and to go beyond where we are without sort of undermining the financial sources and responsibilities that currently make coverage available. So from background to the coverage and access provisions of the federal law. This is an overview of all the different ways that the federal law seeks to expand coverage. And just a word here, coverage matters in assuring access to health care. So it is a necessary condition for most people to get into systems of healthcare and have their healthcare seen in a systematic way. But it's not always a sufficient condition for access to care. And again, a little more about that in just a minute. But within the overall goal of the Affordable Care Act, to get many more people, a much greater share of our uninsured population, that 20% in California covered, there are all these different tactics to do that. There is a broad expansion of the Medicaid program. There are insurance market reforms, which Karen mentioned, new individual responsibilities to obtain coverage somehow or face penalties, new employer responsibilities to make coverage available, and finally, the establishment of these mechanisms called the insurance exchanges, which I will discuss in just a minute. In terms of changes to Medicaid eligibility, importantly, from my perspective, in terms of assuring a more equitable access to coverage and care, the ACA for the first time will expand coverage to everybody up to a fixed income level. 133% of federal poverty, or because of some sort of arcane rules, 138% is probably the more accurate way, because there are some accounting details there. So everybody, those poor adults that I mentioned have been left out altogether to date, will be eligible for Medi-Cal. The children who currently only qualify for Medi-Cal up to 100% now are in the Healthy Family Programs would move over to Medi-Cal, where benefits are different, a little bit more generous. There are also provisions to simplify the standards that are used and the process by which people qualify, which should make it easier both to get people enrolled and to know whether or not you qualify and for what program. So back to that same chart I had before, you see more uniformity across those red bars. Everybody up to 133%, regardless of their situation, will, in 2014, qualify for Medi-Cal. And then building on that, California will continue to offer coverage to some infants and pregnant women, and others will be seen, other kids will be seen through Healthy Families. Private insurance changes, a quick summary of the changes in the Affordable Care Act, and all of the ones I describe on this slide will take effect in 2014. There is, as Karen mentioned, guaranteed issue in the individual market. It's hard to emphasize what a change this is from today. Today, if you want to buy individual coverage on your own, no matter how much money you have and are willing to spend, health plans can turn you down if you have conditions that they feel will make you so costly that they don't want you in their pool of people covered. And for that reason, there are many people who simply cannot buy individual insurance at any price, and even those who do buy it often struggle with the level of benefits and the cost that they are asked to pay. In 2014, health plans will no longer be able to medically review people and turn them down in the individual market. That is counterbalanced by the notion that everybody is supposed to get coverage. So people are not supposed to be able to just jump in and out of the coverage, out of the market whenever they need it. And that's the concern that insurers have today. There will be subsidies available through the exchange to help people afford coverage. And these will, on a sliding scale basis, help people up to 400% of the federal poverty level, which is about $38,000 for a single and $88,000 or so for a family of four, to afford that coverage. So they have to buy, but they get some assistance, and the scale slides with higher incomes. Small, low-wage businesses also are eligible for some discounts or some federal credits against the premiums that they pay if they meet some very specific requirements. They have to be quite small, and their average wage level has to be really pretty low, $50,000 average annual wages. Already mentioned the mandate and the penalties we can talk more about if that's an item of interest down in questions. So what is the health benefit exchange? And as I'm talking about this, I realize maybe I should have said that sooner since I already mentioned it a couple times, but let me just pause and say what I and what we in general mean by that. The federal law envisions these structures called health benefit exchanges that will be established and run at the state level, or if states decide they are not prepared to do that, there will be a fallback option at the federal level. And these exchanges will be sort of a central cog in the mechanism of getting more people covered. And the way that they are envisioned to do that is that they will offer a structured selection of health plans that will make it easier for consumers to choose and evaluate their choices. So think of it as an organized, structured, policed, if you will, that's a little bit harsh a word, but a structured set of choices that meet federal qualifications and that are available to people that they can compare side by side. The exchange is also the only access point for these federal subsidies to assist in affording coverage. So there will be an individual market outside of the exchange, there will be a small group market, but you can only get federal help paying for it if you purchase your coverage through the exchange. And finally, the exchange will be a vehicle by which you come to one place and there is a means for determining what program you're eligible for. Based on my circumstances, am I eligible for Medi-Cal? Am I eligible for subsidies? Am I eligible for none of these, but still need to go find out how to get coverage on my own? Coverage estimates, the main takeaway on this slide is that there is expected to be a big shift and a big increase in covered Californians, particularly a large increase. This amounts to about 20 to maybe even 30% increase in enrollment in our Medi-Cal program, which is quite significant when you consider that the current Medi-Cal program struggles to serve all of the eligible people effectively in terms of access to providers. I too am going to make a couple of cuts here. The federal law does increase provider payments on a temporary basis for primary care providers. And this is important given the challenges with access that I mentioned earlier. This data that I'm presenting here shows you that currently Medi-Cal providers are reimbursed at a rate considerably below Medicare and commercial providers, and increasing that should help people get access to the care that they need so that insurance is meaningful, not just a card, but actually access to care. Important notes in terms of financing, there is new federal funding to reimburse for many of these coverage expansions. In particular, for the newly eligible population, in the first 2 years of the Affordable Care Act's implementation, those people will be covered 100% through federal funds. It won't be an additional state burden. However, the current match still applies for people who are eligible under rules today. And this is potentially problematic for the state because more people may decide they'd better get enrolled in an era of a mandate and penalties. There are some other changes in federal funding that are also intended to improve access to care, noted here. So I want to give a quick update to conclude my remarks on where California is with respect to implementation. So though the law is federal, it requires considerable activity and delegates many implementation responsibilities to states, including California. And California, in the last months of the Schwarzenegger administration, actually moved quite quickly to take some steps toward implementation. In particular, legislation passed last year to establish California's health benefit exchange, made more specific some of the federal requirements around the exchange, and set up a governance system for that body. And the other way in which California is advancing independently of the federal law or in concert with the federal law is through our recent Medi-Cal waiver, which seeks to do many different things to improve access to care and to modernize Medi-Cal, but in particular allows expansion of county programs with local money to cover more people who will in 2014 become eligible for federal funds, and then also take steps to modify the delivery system at the local level through new incentives to be accountable for quality and outcomes. And so, what remains to be done? Well, a huge number of things remain to be done. There are a lot of open questions and a lot of legitimate concerns. One is with respect to the impact on state spending. Again, the federal funds are generous at the beginning for some populations, but there will likely be some impact on state spending, and in our fiscal environment, that's huge. There are good questions remaining about how well this coverage will translate into access to care. There are many open questions about the best way to move from the current system we have for determining eligibility and enrolling people in the right program to the vision of the Affordable Care Act, which is a single, very consumer-friendly mechanism to quickly get people into the coverage that they're eligible for. There are other opportunities I mentioned here around coordinated purchasing and delivery system reform, which we can go into in questions and answers if you are so inclined. And I will just say that CHCF has a wealth of resources on our website that I or Terry can point you to if you are interested in using some of them.